Slide, please.
Go ahead, sir.
And this, a very good afternoon to all of you. My name is Dr. Prasanta Kumar Nayak. I'm the clinical head and fertility consultant at Oasis Fertility Hospital, Bhubaneswar. So today we'll discuss about the use of progesterone in the treatment of infertility. For the understanding of all those people, I must say that you must be knowing that in the obstetrics practice, or especially in the practice of infertility, when we perform a lot of treatments like IUI, IVF, or even OITI, even medications we give for pregnancy, we use different kinds of medications, and out of that, you must have heard about that. We use some kind of hormones. Some people have some negative feedback and some apprehension regarding, yeah, this is a hormone, that is that. So whether it will be helpful for them or whether there will be any harm. So all these doubts and dilemmas and misconceptions, I can say, are there in our mind. So today we'll discuss about a hormone called progesterone. Then what is this progesterone and when it is used, and whether it is helpful for the pregnancy or the child. So all these points briefly I'll describe. I'll not go into the depth of this all these biological things, but I'll tell about the normal usage and where we should use it, where we should avoid it, whether we should be afraid of it or not. So progesterone is one of the hormones that is commonly found in the female, and along with another hormone you must be heard, that is estrogen. So estrogen is the predominant hormone in a female's life. That is also known as the female hormone, which is responsible for mostly for development of the means the sexuality and the sex organs like uterus and all these the breast development and all these things. And progesterone is also another hormone which is also equally important for femininity and all these functions of the female physiology. So out of that, and these hormones, estrogen and progesterone, are being secreted from the ovary mostly. And when if a lady become pregnant, usually the estrogen level goes to a baseline, and the mostly the progesterone predominates, because progesterone is also known as the pregnancy hormone, and usually it is required to maintain the pregnancy. And usually when there is lack of progesterone in the body in a pregnant lady, usually it leads to miscarriage. So there occurs abortion if the progesterone level is lower or it is not sufficient enough. The pregnancy cannot be carried out further. So progesterone is very important, mostly to in maintaining the pregnancy and keeping the growing child inside the uterus safer. So to know about more and more that when and how we should use, I'll just go through some of the slides. As you can see, that one of the biggest professional stress of an obstetrician is to deal with bleeding in early pregnancy. So early pregnancy bleeding is a condition where a pregnant lady suddenly starts bleeding and she is just few months pregnant. And this is just a nightmare for our practice, because when we give someone become pregnant out of IVF or IVF, we are so happy, and the happiness in the patient, in the feeling of the patient also gives us a lot of hope that yes, they are going to have their child. But suddenly she informs us, or she lands to our hospital that she's having bleeding, even if she's just 1 month or 2 months pregnant. So definitely it becomes a bigger stress for us, and of course the patient is in a bigger stress and all this pain and all. So in such situations, what we do, we just try to treat them with different kind of medications, out of which the treatment with progesterone is also very important. So there is a condition called luteal phase deficiency. Luteal phase is the phase of the cycle or the ovarian cycle just after ovulation, when there occurs early pregnancy, and there is a corpus luteum. That is after the egg is released from the Graafian follicle, that becomes corpus luteum, from which the progesterone is being secreted. And these progesterone are sufficient to maintain the pregnancy. But sometimes this luteal corpus luteum phase is not sufficient to the progesterone secreted from this corpus luteum is not sufficient, so that the pregnancy is affected, and that leads to all these kinds of issues like bleeding, there will be pain, or even it can lead to abortion also. So low progesterone and the environment created iatrogenically also, because these are some of the natural conditions where the corpus luteum is found. But if you are using IUA or IVF, especially IVF, where there is no corpus luteum, so in that case, we used to give high doses of progesterone to the females so that the natural progesterone level is maintained and the pregnancy is maintained. But in case of a natural pregnancy or IUI pregnancy or YTI pregnancy, where we find there is progesterone deficiency, we also add progesterone to the treatment so that our pregnancy can be continued. So if you'll see IVF exclusively, those patients who are planning or who have already undergone IVF, they must know that, because here we are using controlled ovarian stimulation. That means we are stimulating the ovary with use of medications, injections, tablets. So all these conditions and after that we are just removing or doing ovum pick-up. The oocytes are being picked off under anesthesia. And after that, we usually we do freezing of the ovaries, means embryos. So these embryos are being transferred in another cycle, in another HRT cycle or natural cycle, where usually we don't allow the ovaries to release the eggs so that there is no natural corpus luteum. So definitely there will be a luteal phase deficiency or decrease in the progesterone level. So all those conditions we use extra support of progesterone, because if there will be low progesterone, then that will be reduced embryo implantation. The embryo will not implant with lesser progesterone. And there will be also delayed endometrial secretory transformation, so that will lead to lower pregnancy rates. And also certain luteal phase of less than 10 days also also has been found to increase the miscarriage rates. So it has definitely some adverse effects on the ongoing pregnancy or even in the implantation of the embryos. So there is a need for luteal phase support, especially in IVF pregnancy, because we have to counter any luteal phase insufficiency during GnRH agonist therapy. We have to give correct abnormal luteal estrogen and progesterone secretion also, and we have to strengthen the endometrial maturation and receptivity, because the estrogen, the progesterone leads to increased receptivity of the endometrium. And that's why the timing of initiation of luteal phase support in fresh embryo transfer, usually if you are doing a fresh embryo transfer, then even if it is there is corpus luteum, we do provide progesterone support externally, mostly on the day of ovum pickoff or maximum the subsequent day or the next day. Around 7 to 1 or majority of the doctors or practitioners, they start progesterone on the same day of egg collection, because that will give extra level of progesterone, so that after day 3 or day 5, when we just transfer the embryo inside the uterine cavity, the endometrium is ready for to receive the embryo. So that helps in the receptivity and the pregnancy rate. But that's why along with that, if it is a fresh or frozen embryo transfer, either cases, always luteal phase support is very, very important. Like fresh and FET are different with respect to hormonal dynamics, but they need some amount of support. Although in the fresh cycles, the support can be lesser, the requirement of the support can be lesser, but in the FET, means frozen embryo transfer, here we freeze the embryo and transfer it later on. So there definitely we need progesterone support always. The progesterone for embryo implantation and early pregnancy support is important, because it is important for endometrial growth of a successful implantation. It suppresses the uterine contractions. It is a relaxant property which questions the uterine contractile property, and it modulates the immune response also. If there are some immunoproblems in the uterus and which leads to rejection of the embryos, it helps in immunomodulation also. And also the progesterone suppresses the deleterious maternal immune responses, as I told, that it prevents maternal rejection of the trophoblast. It modulates the effects of the T helper and T helper 1 and 2 cytokines, therefore increases the receptivity and the continuation of the pregnancy, and the inflammatory action is also reduced. And if you'll see the effect of progesterone on the myometrium means the muscle of the uterus itself, then it has been found that it is one of the major mechanisms of progesterone action in maintaining the pregnancy is inhibition of the contractions of the myometrium. Therefore, research has demonstrated the relaxant effect of progesterone on the myometrial strips in vitro also. There are some researchers where they've added progesterone to the muscles and they found that there is no contraction. So it has an effect on the myometrial contractions. It prevents the myometrial contractions, which prevents expulsion of the growing embryo or the fetus. And progesterone as a luteal support after ovulation induction in intrauterine insemination. If you'll see the IUI, whether if it is required in IVF is already I told, whether it is required in IUI, that is intrauterine insemination. And there are studies which have shown that if we are using only ovulations, that is the either if you are using gonadotropins, that means LHRI facies, that is for ovulation and auction, then we should always use the luteal phase defect, because use of gonadotropins decreases the corpus luteal effect. And if you are using mixture of ovulation, if you are using mixture of ovulation, means either letrozole or clomiphene along with gonadotropins, then in such situations we may or may not use the progesterone as the support. But if you are using only clomiphene citrate or letrozole, not the gonadotropins, then in such situations, the requirement of luteal phase support in the form of progesterone may not be there, is not there actually. As per evidence, it is not required, but it depends on the practice and the people's experience that whether they'll use it or not. But that's why, again, after knowing that, yes, progesterone use is required in certain situations in the practice of infertility or in the early pregnancy, even there is threatened abortion or there is some kind of bleeding in pregnancy. But which progesterone we should use? There are various formulations of progesterone. It can be oral progesterone, it can be injectables, it can be vaginal suppositories, so many things. So once it is found that oral micronized sustained release progesterone was as effective as vaginal micronized progesterone, so either you can use orally or you can use vaginally, but the but it depends on that which one you want to use for the patient's compliance, and the patient's acceptability is also very, very important. But either of the progesterone can be used. And it has been found that micronized progesterone and dydrogesterone nowadays it is used a lot. So if it is combined together, and when it is compared with the use of micronized progesterone alone, that they need trial in frozen third cycle of the IVF, means FET cycles, that is known as Medron trial, where they have found that the combination of dydrogesterone and progesterone, micronized progesterone, has found to be improved outcome, higher live birth rate, significantly low miscarriages, and low birth rate. So if you are combining these two, progesterone is also good than using rather only one micronized progesterone. Similarly, there was a phase 3 randomized control trial of oral dydrogesterone versus intravaginal progesterone gel for luteal support in IVF, which is found, that is known as Lotus trial, where they found that higher rates of ongoing pregnancy and live birth in women receiving oral dydrogesterone for luteal phase support. Dydrogesterone is superior, they have found in Lotus trial, in fresh IVF cycles as compared to micronized vaginal progesterone, while no significant difference in the incidence of congenital, familial, or genetic diseases. It is not affected in congenital defect or any kind of familial or genetic disease has been found. It's strong. Similarly, the progesterone is also used in case of preterm birth, and especially in short cervix, and the cervix length is less than 2.5 centimeters. And it has been shown that there is a sonographic cervical length measurement should be performed in all pregnant women, especially during the this animal scan if it is found less than 2.5 centimeter. And either you can go for suturing. Most of the doctors are in the practice of go for suturing, but you can use these progesterones also, which can also avoid the necessity of using some suturing, means NSAIDs operations. And an ACOG recommends that patients with prior spontaneous preterm birth and singleton pregnancy be offered progesterone supplementation, and 90 milligram vaginal gel or 200 milligram micronized vaginal soft capsules or 250 milligram of 17 hydroxyprogesterone caprate. We have some injectable forms, Prolutin, to prevent recurrent preterm birth. And therapy started around 16 to 20 weeks of gestation and continued until 36 weeks. It should continue up to 36 weeks. And so there is trial called Prolong trial, but it is found not much efficacious even by the optimum trial. But many studies or recommendations supports the use of this. So use of progesterone in twin pregnancy also. Cochrane review included 6 studies where a single weekly doses of 250 milligram intramuscular 17 progesterone was compared with placebo, but they found no benefit actually for twin. But women with twin pregnancy, in events trial, the women with twin pregnancy, universal administration of progesterone at a dose of 300 milligram twice per day from 11 to 14 to 34 weeks gestation, they have not found any much significant reduction in instances of preterm deliveries and all, but still people sometimes they prefer to use this. Well, after knowing that which progesterone we should use, let us see that what should be the ideal route of use. That means orally, vaginally, intramuscularly. So the transdermal route or subcutaneous route has are more means acceptable because that does not they're less painful and this can be used easily. But intramuscular dose route, though it is painful, but little more effective, of course. And some people are also hesitate to use it intravaginal, but intravaginal route is also better than oral, because in oral route there is more of fast metabolism, means that gets digested. So well, in that case we have to use more, the amount to be used to be more. So the route, whether in the Cochrane review, here the treatment with oral progesterone probably reduces the miscarriage rate compared to no treatment, but while treatment, the vaginal progesterone demonstrated minimal reduction. So in the Cochrane review recommendation also tell that definitely if you are using orally, which reduces the miscarriage if you are not using at all. Even you can use the vaginal route. Progesterones also increase the live birth rates and reduce the risk of miscarriage, with benefit only seen with oral progesterone. And many people favor the use of oral progesterone, that is dydrogesterone and all. Then what should be the doses? There are different doses usually used as oral dydrogesterone. We can use up to 20 to 40 milligram. If it is a vaginal route, then we can use up to 1800 milligram. If it is gel, we can use up to 90 milligram. And if it is injectable progesterone caprate, then we can use either 250 or 500 milligram weekly doses actually. And the nice guidelines recommends that vaginal micronized progesterone at the doses of 100 milligram twice daily should be prescribed to women with a confirmed intrauterine pregnancy and previous history of miscarriage or present with vaginal bleeding. So usually, if you are using vaginal route, usually micronized progesterone 400 milligram twice daily, what we usually use. But as we know that the progesterone seems to be a very friendly drug, very friendly hormone or medicine, you can say, where we are using it to prevent miscarriage, to prevent preterm delivery, to prevent, to continue the pregnancy, to help in more achievement of our pregnancy. But as the proverb says, every rose has this thorn, has its thorn. Then there must be some other side effects also that we should be aware of. There are some safety limitations of progesterone in pregnancy, like a meta-analysis has shown that probably no difference in congenital abnormalities and adverse drug effects if you are using either mechanized progesterone and all. They found no differences of any kind of anomalies. Also, Promise and PRISM trials, they found there was no evidence of short-term harm or increased risk of congenital abnormalities in women in taking the micronized vaginal progesterone. So they didn't find any kind of abnormalities, side effects or any anomalies. And long-term effects, whether it is affecting the newborns in the childhood development, but the many studies, including this meta-analysis or systematic review, have concluded that no benefit or harm when prenatal progesterone is used for prevention of preterm birth, and there was no significant difference in terms of congenital anomalies with the use of dydrogesterone has been found. But there is some alarm thing that some case reports and others have some of in the literature that we've seen that can be a possible link between prenatal exposure of 17 alpha hydroxy progesterone caprate and a synthetic progesterone, which is synthetic progesterone, and some kind of cancers in the children, especially reported used in first trimester, and more cancer risk among male offsprings noted if you are using more of injectable synthetic progesterone like Proleukin or caprate progesterone, then they have little bit of more chance to develop cancer among the offsprings, especially if they are male offsprings. Male newborns and all. So they have also found with the use of dydrogesterone that they have found a fulminant liver dysfunction in one of the patients where it was used in high dose for longer time. And the most common adverse effects reported by women taking just complications are these are some of the complications that sometimes it has been reported in the literature. So always while talking about the advantage or the good effects of some drugs, usually they become very favorite and they are being used, and many times they are misused also. But we should not forget that anything which is overused, there is a high chance of getting some of the adverse or complications. So at the end, I must have some take-home messages about the progesterone use in pregnancy or in the treatment of infertility. That progesterone is essential for the establishment and maintenance of pregnancy. Progesterone supplementation is used therapeutically for several obstetrics indications like threatened abortion, RPL, recurrent pregnancy loss, or IVF. However, in those presenting with bleeding in early pregnancy and a history of previous miscarriage, progesterone therapy may be effective in improving live birth rates. Definitely, it has a good effect. And while using it, we should not forget about the adverse effects associated with its overuse, especially. And further studies are required to answer questions such as the most appropriate indications for use, the preferred doses, the route of administration, the duration of treatment, and also the cost effectiveness. So thank you very much for your patience listening to me. And I hope that this brief description of the use of progesterone in the practice of infertility or in the maintaining the safer pregnancy is definitely there, and I hope you get some information from my presentation. Thank you very much. If there is any questions, I'll be glad to accept them. Thank you. So there is a question that how to use progesterone for infertility. As I told, that progesterone is mostly used for luteal phase support or in the early pregnancy conditions, especially if it is IVF. Definitely we start it immediately following the or just before the embryo transfer, then following the embryo transfer, and it is continued till few months of pregnancy once she becomes pregnancy or UPT positive. And if it is like tablets or ovulation induction, usually it is not essential. But if you get any kind of previous history of miscarriage or she has some bleeding and all, even if it is ovulation induction or IVI, we always use progesterone to support that pregnancy. Yes. Any more question, please? What are the benefits of hormones treatment for infertility? Is next question. Yes, there are so many hormones usually we are using in the treatment of infertility. Some form of hormones, as I told, gonadotropins and all, they usually help in ovulation induction and in the ovulation. And once it is ovulated, and if there is pregnancy or we want to expecting the pregnancy, also start supporting that person, or after IUI or after embryo transfer, we give progesterone to support that pregnancy. So it has a role in the ovulation induction or in the creation of the oocytes or the egg, you can say, and followed by even in the maintenance of the pregnancy. So there are so many benefits of these hormones, but as I told, that the use should always be justified and indicated, should be used in cases of indications, and we should always avoid overuse or misuse. Yes. Anything else? Questions? How does progesterone prevent fertility? How does progesterone prevent fertility? Okay, the progesterone directly it's not doesn't prevent fertility, but when it is used in the form of contraception, either alone or in combination with estrogen, so definitely it prevents the release of gonadotropins. That's why there occurs the growth and means ovulation is prevented. So it also prevents because that's why it causes prevents the sperm migration. So it leads to mostly contraception action, I can say. What is the role of hormones in fertility? As already I told, that these hormones are always used in different ways, either for ovulation induction or for release of the eggs, or after that for implantation, for maintenance of the pregnancy, and to prevent bleeding or in the early trimester threatened miscarriages. All these conditions it is used. Question, please. Thank you. Hope and wish you all a very good evening, and see you in our next session. Thank you.